light in the dark. Miss N, 28-year-old lady from Arunachal Pradesh, has come to CMC with chief complaints of abdominal pain for 2 years and abdominal distension for 9 months and weight loss for 9 months. History of presenting illness. History of abdominal pain for past 2 years is intermittent and increased in intensity. History of progressive abdominal distension and history of weight loss 10 kg over 6 months. No history of dysphagia, vomiting, hematemesis or melena, diarrhea, dysuria, hematuria, and decreased urine output. No history of fever, cough, breathlessness, joint pain, headache, and loss of consciousness. And no history of oral ulcers or alopecia or skin rashes. Past history. Before 2 years, she got an abdominal pain and got evaluated in local hospital, presented with left empyema and under decortication. And diagnosed as probable tuberculosis, not microbiologically confirmed, took ATT for 9 months and stopped. Again, on March 2023, she developed progressive abdominal distension and underwent large volume paracentesis and upper GI endoscopy. Eosinophilic candidiasis found and treated. On September 2023, again recurrent abdominal pain, abdominal distension, underwent multiple large volume paracentesis and had been done. Personal history, consists mixtape, disturbed sleep, menstrual history, amenorrhea from March 2023. On examination, her vital signs were 100/60 and pulse rate 88, SpO2 98, and conscious oriented pallor present. There is no ictus, sinuses, clubbing, lymph node, vital edema, JP not elevated. And the bitemporal hallowing present and loss of buccal pad of fat. On inspection, abdominal inspection is uniformly distant. Other than shifting dullness, there is no positive findings. Serious S1, S2 here. No murmur, respiratory system normal, vesicular burst sounds here. Central nervous system is normal. On summary, 28-year-old lady with chronic ascites, abdominal pain and significant weight loss with pallor, fluid 3, bitemporal hallowing and loss of buccal pad of fat. My syndromic complex were ascites with weight loss.
Okay. To use the mic or come closer to the mic.
Syndromic complex would be ascites with weight loss. Can be due to tuberculosis. Because the patient has a past history of tuberculosis, it can be due to portal hypertension and early or late Budd-Chiari syndrome and nephrotic syndrome and peritoneal malignancy, pancreatic ascites and peritoneal cirrhosis and autoimmune hepatitis. So investigations, her HB is 9.3, it's normal, and platelets 2 lakhs, WEC 6,500 and normal RFT. And this LFT was normal. And analysis, her cytology is negative for malignant cells and WBC 450, RBC 2400, and in found to have low sac ascites. And culture negative for bacteria, fungus, and RF expert TB negative. And here adenosine deaminases 4. So first we thought of a malignancy and we had done CEA, which is normal, and CA 125 is elevated, 156, and CA 19/9 is normal. And we did an autoimmune hepatitis workup, which is negative, and IgG4, which is negative. After that, we did ANA, which is 3 plus speckled, and dsDNA is 849, and direct cum test is 2 plus positive, and APLA workup is negative. And USG abdomen shows ascites and mild hydroerythronephrosis and left mid and distal urethra. USG ARFI to rural cirrhosis, which is within upper limit of normal range. CT thorax, abdominal pelvis has shown marked ascites with omental thickening with standing and diffuse edematous bowel loops and multiple retroperitoneal thickening with mild urethra. Summary, Miss N, 28 years female with recurrent episodes of ascites, abdominal pain with low sac ascites with elevated ANA, dsDNA and raised CA 125 levels. Diagnosis, it is found with systemic lupus erythematosus. On 2019 EULAR and ACR score is 19 and CELDI score is 8 and with pseudo-MEG syndrome. This is the assessment of patient with ascites. We can divide it into low sac, high sac. In low sac, our patient has low sac, so her differential will be biliary nephrotic syndrome, pancreatitis, and peritoneal carcinomatosis and tuberculosis. High sac ascites is divided into low ascitic protein and high ascitic protein. In low ascitic protein, we divide into cirrhosis, late Budd-Chiari syndrome, and massive liver metastasis. And the high protein, it will be heart failure, constrictive pericarditis, early Budd-Chiari syndrome, IVC obstruction, and sinusoidal obstruction syndrome. It's a pseudo-make syndrome or Tachlama syndrome. It can be present with ascites, loculated pleural effusion, and elevated CA-125. Without benign or malignant ovarian tumor, it's a new emerging manifestation of systemic lupus erythematosus. There are some 15 case reports presented with Tachlama syndrome, and they all presented with ascites and multiloc pleural effusion and increased CA-125 levels. And another thing in this patient is large volume effusions presented with. It's also very rare in SLE, and sometimes it can occur in SLE due to the complications such as constrictive pericarditis, heart failure, or Budd-Chiari syndrome. Only a small number of cases for SLE with massive ascites is presented. So there is also some case in the literature showing this kind of features. Our patient is started on prednisolone 1 milligram per kilogram and mycophenolate mofetil 500 milligram and discharges stable condition. My learning point is you have to know that SLE can be present at initial stage as Tachlama syndrome and massive pleural effusion. So we can stop unnecessary investigation and start appropriate treatment as soon as possible.
Thank you. No, actually, we have not diagnosed pseudo-make syndrome till now. It's a very rare disease. I mean, it's a very rare, it's just emerging as one of the manifestations of lupus. As she said, there are only 15 cases. But finally, you have to treat with corticosteroids. So I think the CA-125 was the clinching point in this patient. It's just an emerging entity. The pathophysiology and all of this entire thing is not explained. So shall we wind up? You can choose. I feel Dr. Namrata did a good job of presenting, conveying her